Professor Thornhill received his PhD in genetics from the University of London. Following postdoctoral work in single-cell genetics at the Institute of Child Health, Alan trained as a clinical embryologist before directing IVF laboratories in the US and the UK. He specialized in pre-implantation genetics and is currently registered as a clinical scientist by the UK's Health and Care Professions Council. Alan is an honorary professor in reproductive genetics at the University of Kent and is a former deputy chair of the ASHRAE PGD Consortium, chair of Alpha Scientists in Reproductive Medicine, and a professional member of the UK's fertility regulator, the HFEA. And since 2017, he has been Igenomix UK's country manager and senior scientific advisor. Welcome, Alan. Thank you for joining us today.
Thanks, Vivi. Okay, let me share my screen.
All right.
Okay, thanks for that kind introduction. This is really exciting. I don't normally get to talk about funding. I normally talk about genetic tests. So I am going to mention genetic tests, but right at the end. The previous talk was super interesting. I mean, very detailed, and I'm not going to provide that level of detail, partly because you won't all be familiar with the UK system, but I think the principles are all fairly similar. I'm going to be talking about UK pounds, but I won't have the level of detail as I've said that we've just seen. But I can tell you that the UK pound is so weak at the moment, it's very similar to US dollar. So you can look at it and think a little bit more equals US dollars. Okay, so let's get onto a brief history of fertility funding in the UK. As you probably all know, the first IVF baby eventually born in 1978, Louise Brown. That wasn't a funded attempt. In fact, most of the IVF attempts up until that point worldwide were, not publicly funded, because this was very much considered an experimental treatment. And I'm pretty sure everybody knows that there were at least 100 failed attempts before the first successful one. And the reason I mention that, might think that's not relevant to this talk, but we're very lucky around the world, but particularly in the UK, that something eventually got funded when it was so unsuccessful. Now, I mean, I know that's how progress works, but I've shown all those headline newspapers from the time, but those are the positive ones. There were quite a lot of negative ones as well. But since the 1980s, and I don't know the exact date, but there was some NHS, and when I say NHS, I'm going to use that term a lot. It's the National Health Service in the UK. So one way of looking at that is that's sort of state-sponsored health insurance. So you pay that through your tax dollars, but it's not a separate insurance scheme. And I am going to be differentiating between, private health insurance, company insurance, and NHS. So NHS means you're a taxpayer, and even if you're not a taxpayer, you get free treatment at the point of care. So I'm going to be differentiating between NHS and non-NHS as we go forward. And I mean, I trained with somebody who, began some of the first NHS funded work in the 1980s. And it was just very patchy provision though. So that's the important part there. Then we get some guidelines in 2004. So quite a long time since the beginning of IVF in this country, from what's called NICE, which is the National Institute of Clinical Excellence. So this is a body that provides guidelines that basically says what should the health system fund, and that it goes way beyond IVF and fertility. So it'd be cancer, all kinds of other care. But 2004 is when they got round to writing guidelines about fertility. So like I say, patchy state provision until that time. And then after that, they made some very clear rules about what should be funded. But the important thing is those rules were, let me put my pointer on, those rules were non-binding, which basically means the rules are there, but if you don't want to follow them, don't follow them, which is not very good for patients. Let's put it that way. And you'll see that in a minute. The total number of cycles in 2021 is around 70,000. So not, nowhere near as many as we've just seen from Japan, but, it's a mature IVF market, and that's a very recession-proof number. This is from validated, verified data. The HFEA is the UK regulator. And as we heard in the last talk, IVF is now considered much more routine as a treatment, and there's a lot less stigma attached to it. So, the demand is there and the need is there. And I'll cover that a little bit in my concluding remarks. And today, about 70% of cycles are private, meaning out of pocket in some way, or private insurance, versus 30% publicly funded IVF cycles. And that ratio has pretty much flipped. Obviously it started as private cycles. Then we get to, when we got the NICE guidelines, sort of late 90s, early 2000s, we've got a lot more public funded cycles. But then we get this massive surge in private cycles as an opportunity, and as public funding kind of dries up for lots of different reasons. And we can talk about that in the Q&A. The NHS tariff, i.e. what's provided for a publicly funded cycle, and we're talking about the sort of basic routine cycle that we heard in the last talk, is around £3,500 to £4,000, which, as I said, is now probably about $4,000, $4,000 to $5,000, and that's without any add-ons. I hate the term add-ons, but I suppose it's a useful phrase to use. And then private cycles generally, and we're talking about basic and routine, start at about 5,000, so a little bit more. But the truth is, and I told you my declaration of interest is, I offer some of these add-on tests through Igenomix, but I speak to patients outside of that, in sort of coaching, in a coaching mode, and they often say to me, the price list of what I think I'm going to pay says about 5,000, but by the time I leave the clinic, I have a lot less money. So that number can go. I've put plus. There are clinics where you could end up spending £20,000 when you thought you were only going to spend 5,000 through add-ons. And that's where I think there is a problem with add-ons. It's a case of, are they evidence-based? Are they really focused on that particular patient and their particular needs? And that's where I think the government and the regulator and the private sector could work a lot better together, rather than just being in opposition. And so what we end up with is a funding system that's fragmented, as you will see, lots of different options for how to pay, which is good in a way, but it's not good when you're a confused patient wondering what you're going to do. It's confusing and it's not really fair. And I'm going to show you some inequity in how fair it is in a second. So let's go through the different sort of funding models then. So we've got the fully funded NHS model. This is, a patient where they're going to get, all of their treatment provided for free at the point of care. And as I said, about 30% of cycles in the UK get that. It's declining though, and there are lots of reasons, and we could talk about that in the Q&A. And I'm sure those reasons are not UK specific either. And who pays? Well, the taxpayer ultimately, but it's done through clinical commissioning groups. This is just a new term for a group of people who sit around in a certain region in the country, who tender for services and procure services for patients in that region. So it's like our country split up into lots of different regions, and they're called clinical commissioning groups today. They had a different name yesterday and before, and they decide how the money they have gets spent in that area, which means that the NICE guidelines that I talked about might end up going out of the window, because they might say we have a particular burden of cancer in this region, so we're going to focus all our attention on cancer and all the other routine medical care that's required. So what it's been known as in the UK for a long time, IVF funding has been considered a postcode lottery. It turns out that some other areas of care, cancer and other things, can also be a postcode lottery. You might not get certain levels of treatment depending on where you live in the country. And that's really unfortunate. And that's what I mean about unfairness, because there's points where you literally could be living in a street, one road across, and you could get different levels of funding for IVF, which is just nonsense. Then we have a thing called self-funded NHS. So this means you've got an NHS centre, a bit like Dr. Harada's university centre, so one that pretty much does things in a state-funded way. But if you have finished your funding, there's no funding left available to you, or you're just not eligible for funding, you can go through what's called self-funding. So it's essentially as if you were an NHS patient, but you pay everything out of pocket and you get basic IVF as above. Then we get this other thing. Now, this is the one I have the biggest problem with. Fortunately, it's a very small percentage of cycles, but it's called private on the NHS. And it's exactly the same as self-funded above, except you get a few extras, but the extras aren't advanced medical care in terms of add-ons. It's things like you get a named consultant, and maybe that has some value, but in terms of getting additional material things for your cycle, you don't really get that. So it's almost like you just walk through a different door, and you pay slightly more than you would if you were self-funding. So I'm not sure what the value of that is, but maybe it's just a marketing tool within a sort of NHS centre. And there's a question mark over whether some rules are being bent to allow some genetic tests to be added as part of that state-funded cycle. So I was really interested in the last talk because I wasn't familiar with the system in Japan. And I think this is definitely a question we should be discussing in the Q&A, is this issue of, if you do something like PGTA, and I'm not promoting it, I'm just making the point, if you do something like PGTA, I don't fully understand the reasoning why you have to pay for the entire rest of your cycle, and none of that gets supported. And that system is exactly the same in the UK. So I don't get it. If you are eligible for funding, but you say, I'd like PGTA, suddenly you have to pay for everything. And I think that needs a good explanation and a good discussion. And then we get things like employee benefits. This is a minority sport. Not much IVF is really being funded by employee benefits. Obviously, the employer's paying, but in a sense, the end user, the patient, is paying because that's part of their employment. But it's a very limited menu, and it really varies by the employer. So it's very hard to say this is how IVF is funded in the UK. Then we have more general insurance, and this is why I wanted to use the insurance word here instead of NHS. So these are opt-in schemes. So this is not something like you get in the US, where pretty much if you work in any company, you have to buy into the insurance scheme. This is very much I'd like to buy into this scheme, or this is a benefit in kind for working in that company. And there's just a few examples of some large health insurers in the UK. And they're general health insurers. They're not specific to fertility. But as I said, it's a taxable benefit. So it's not exactly, completely free. But it's a very limited menu, again, varies by the insurer. And we'll cover that a bit later. And then let's get to this is where the action is really. We should be focusing our attention. And I say, unfortunately, it'd be lovely if more patients were state funded. But the truth is, it's declining, and I don't see any reversal of that. Definitely another point for questions and answers at the end. But 70% of our cycles in the UK are now private, which has led to this massive boom in the fertility industry. And I know clinical people hate using the term industry, but it has become an industry. So this is all out-of-pocket payments from patients, and there's a large menu of add-ons. And I'm glad that the previous speaker started talking about some of those. Which includes genetic tests, and we'll cover that briefly towards the end. So a quick guide to public funding. So the state-sponsored cycle is what we would call National Health Insurance, National Health Service. I've talked about the National Institute of Clinical Excellence. Well, so this is their basic terminology. So after 1 year of unprotected intercourse, the family practitioner, the general practitioner, GP, can refer you for fertility screening. And so let's call this phase 1. So this would cover all the usual things: blood work, see whether you're ovulating, semen analysis, infectious disease screening, because that's part of the mandate for if you go through IVF, or if you go through fertility treatment, you need to be checked for that. Damage to reproductive tubes, the sort of basic investigations, if you like. And then because this work will have been done through a more specialist service, you now could potentially, depending on the diagnosis, go through to the treatment phase. And the treatment phase can have, 3 different modalities, really. Maybe it's just drugs. Maybe it's just drugs supporting ovulation. And it could be all of these, but, these things can all happen independently as well. It might be surgery, different types of surgery there, or it might be assisted conception. And obviously, for the purposes of this talk, I'm going to focus more on IVF and associated treatments and add-ons. But, lots of things are covered. And to keep it simple, I haven't gone into things like sperm and egg donation, but we have a very liberal system in the UK. It's tightly regulated, and as you'll see, the funding isn't. It's generous, but it's decreasing. But actually, we're very lucky that some people can get egg donation and sperm donation paid for from the state. So it's all allowed and some of it is funded, but it's a very patchy provision. But the general rule, and this is what I heard from the last presentation, and I need to get my head around it and really understand why, is you can't add extra tests into a state-funded cycle. And the other question I suppose I have, which I hope we will discuss, is not just, why is that in principle, but what's the system in each country to determine whether a test, an add-on, now becomes eligible to be funded. So where's the point where it stops being an add-on and starts being a advanced medical care? And that's not clear to me. I will show you some guidelines in inverted commas that we have in the UK, but I'm not sure they're I'm not sure they're as robust as we would like them to be. So I'm just going to go through the different areas of the UK without going into a lot of detail, just to show you the sort of, given that we're supposed to be one nation, the United Kingdom of England, Scotland, Wales, and Northern Ireland, in those 4 regions of the UK, this isn't the street to street analysis. This is just those 4 large, they're independent countries that have become part of a United Kingdom. If you live in each of those regions, you're going to get a different provision of IVF, even though we're supposed to be one nation. So just some examples of the 4 main categories that would decide whether you're eligible for that state funding that I described earlier. Well, the existence of previous children could make you ineligible. Here's a good example. In England, so this is just England we're talking about here, roughly 90% of those regional CCGs will rule you out for IVF if one of the people in the couple already has a child. Some of you listening might think that's fair, but if you know how frequent it is for people to split up and have new partners. So basically the person who hasn't got any children from a previous relationship or has never had a relationship before, they're being penalized because their partner has got a child. So that seems interesting. There's some BMI eligibility criteria. Those more medical of you may think this is quite reasonable, and I don't think this is unreasonable, because low BMI and high BMI, those extremes might make the chance of success much lower. And I do understand that a healthcare system probably wants to not just throw money at situations, but throw money at situations where the outcome is likely to be good. And then, of course, lifestyle, smoking, alcohol, and recreational drugs all are a kind of barrier to entry, if you like. And personally, I don't have a huge problem with that. Again, that's all linked to, showing desire and trying to improve outcomes. And then relationship status. And this is probably more about trying to make sure that, I think this comes from a historic need to preserve the welfare of the child. We've changed that provision over the years. It used to be that there has to be a father, and now it has to be there's a stable family group, which I think is much more reasonable. But then this is changing because of the discrimination laws, but some areas didn't and still don't fund treatment for same-sex couples. It's pretty hard to justify that now with the kind of anti-discrimination laws that we have today, but that's a sort of legacy effect. So then if we go to Wales, I won't spend too long, lots of similar things: BMI, no smoking, no previous children. And now we've got some age restrictions. So men have to be under 55, women have to be over 20, not 18, which is sort of interesting. I'm not sure what the difference between an 18-year-old and a 20-year-old is. So that's interesting. And then we start getting this kind of this 40-year cutoff, which I saw from the previous speaker as well. So up to 2 cycles of IVF in this, let's say younger age range, and in the older age range, 1 cycle, as long as you haven't got low ovarian reserve. So again, similar to what we heard in the last talk, but coming from a different angle. If you're older, you're penalized in a healthcare system. So, and given that more women are waiting longer to have their child, then they really are penalized. Their biology penalizes them, and the state penalizes them as well. I'm not saying that's right or wrong. I'm just pointing that out. Now we've got Northern Ireland. Lots of things similar, as you can see, but if you've had previous IVF cycles, even if they're unsuccessful and you paid for them yourself, you can't have funding. That seems a little unfair as well, but I guess that's based on you've had so many chances for it to work and it hasn't worked. Why would we throw more money at it? And then a very similar sort of scenario for the age groups. And then this is the good news story from the UK. Scotland has the best record for funding IVF. Yes, it has some eligibility criteria here, but if you're lucky enough to, meet those criteria, then women under 40 have 3 full cycles of IVF. And don't forget, well, perhaps I didn't show this, but the NICE guidelines from 2004 said you should be eligible anywhere in the UK to have 3 full cycles of IVF. So Scotland is pretty much the only place that's consistently provided this. Again, this sort of penalisation for being over 40, and I do understand it's because the chances were thought to be, significantly lower. I believe at the last count, Scotland had 62% of people who were eligible were getting 3 full cycles. So that's really good news. Here's just a sort of schematic that shows, to try and explain it to professionals and to the public. We've got this burden of infertility amongst heterosexual couples. We can argue 1 in 6, 1 in 7. Nowadays, we've got at least 5% of service referrals from same-sex couples. So aside from anti-discrimination laws, we should also recognise this is a growing trend. The NICE guidelines recommended 3 cycles of IVF for women under 40, as I suggested, but fewer than 1 in 5 CCGs is funding at that level, and that's really bad. This, I'm not sure what year this is from, but this is a pretty clear indication of what we're seeing in terms of whether different areas of the UK are meeting those requirements. And here we're not showing Scotland and not showing Wales here, but just in England, you can see really patchy coverage of whether you get none, 1, 2, or 3 cycles. And then, as I said, there are even places where you could live in a different street and get a different provision of IVF, which is, just nonsense, really. So, as I said, confusion and unfairness for patients. And in an era where, things like any other consumer item like insurance or buying a car or whatever, you can go onto the internet and find a website, price comparison website, to help you navigate this. You can't do that for NHS provision. I mean, it's just not simple at all. So that's led to lots of patient advocacy sort of groups, creating this kind of checklist for patients. So they say, you have to become a mini expert, check out the rules locally to you. Well, that's hard enough. Find out rules on eligibility, so that, because IVF is a time-sensitive treatment, as we all know. So the age, weight, and whether you've got previous children, you need to have been trying for a year to become even eligible. So that, that's something, start now. Don't wait and then try and get funding. AMH, which we now consider quite a solid tool for, pre-IVF assessment, it's only measured for free by the NHS once you've been referred to a fertility clinic. So it's not even really a frontline test, which is a little bit odd, given that if you go to a private centre, AMH is one of the first things that we've done. And I love this, the rise of digital at-home health and femtech. You can buy AMH off the internet now, done through a proper service. So it seems like the NHS is playing catch up a little bit. You've got a right to a copy of your test results. So if you're going from NHS to private, you should be able to take all that information with you, which is, very obvious. We know about the different numbers of IVF cycles, as I've already explained. And then this other thing, that not all NHS funded IVF cycles are equal. And what I mean by that is, it wasn't on the last slides, but some regions have chosen to interpret the NICE guidelines as a fresh egg retrieval plus transfer is an IVF cycle, and others include all the subsequent frozen cycles arising from that treatment, or just one. So it's not clear for patients. It's really, really difficult for them to navigate this. And of course, they can't move house just so they can get IVF treatment quickly and easily. That's not a simple thing to do. So let's move to private funding. Now, this stuff might be very, very obvious, but I wanted to kind of make it clear how it sort of works. So let's talk the customer paying out of pocket, the obvious sort of private part. And this is when you're paying for it all yourself. You can pay by sorry, this sounds very much like, you know, a sort of advert. You can pay by credit card, payment plan, or cash. You know, clinics will find any way they can to help you pay. It's generally paid up front, and I'm saying this because the way it's often done is that you will get a treatment plan that pretty much says this is all the stuff you could have. You'll pay for all of it, and then if things aren't done, like you don't have embryos to store, or you don't have to freeze, or you don't have ICSI in the end, you get a refund for those treatments. That's how it's generally done. So clinics are sort of making sure that they get what they've planned for. But, and this is one of the better things the regulator has put in place, you have to have a costed treatment plan. And this is essentially a kind of list of things that could happen so that you have a very good idea of how much you're likely to pay by the end. And this is what I meant about at the start. Some customers say, oh, I've gone to this private clinic and I think I'm going to pay about 5,000 because that's what it looks like on the price list. But they come out the other end having spent 15,000 or 20,000. But the cost of treatment plan is to try and stop that from happening, or at least prepare them for what might happen. And then obviously you can pay from loans that are either independent of the clinic, or more clinics are trying to create sort of funding structures within their own organization. And some of that comes through financing that's clinic specific. There's one of our big clinic chains here that actually has their own kind of financing system, or a thing called Access Fertility, which is an independent of the clinic's system of packaging treatment cycles, so that you actually know what you're going to pay and you know what you're going to get at the end. And I'll briefly go through that in a second. And then we've got private insurers, which I mentioned at the beginning, or company benefits, and that varies massively. And that's either you pay up front and get reimbursed according to what's been allowed by the insurer, or you can get a direct payment to between the clinical service and the insurer, or it can be a system of copay. And it was very interesting to see that Japanese system seems to be a copay system, which I've experienced when I used to live in the US, and I was reasonably happy with the copay system. I kind of understood it. It feels like there's both parties are having some stake in it, which I think is sometimes quite good. So here's an example of this is Access Fertility. So this is independent of clinics, but working with clinics. Again, I'm not judging it or promoting it. I'm just saying it's interesting that, and I'm speaking to a lot of patients who are quite interested in these packages. So they have a thing called IVF Unlimited, and this isn't their words, these are my words. This is obviously a high cost. You can have unlimited numbers of IVF cycles. So I don't know what the actual cost is, but I imagine this is quite a high number. And there's no money back on this. This is if you get pregnant and you stop using the service, they probably make quite a lot of money. I imagine there are medical criteria for this, because you wouldn't want someone who has almost zero chance of going through IVF to have unlimited IVF cycles. On the other hand, my question is, since we know from the literature that patients don't like going through multiple times, even if it's paid for, then perhaps they're banking on the fact that people will drop out after a number of cycles. Then we have what's called an IVF refund program, which is very interesting. Now, this one, we definitely have medical criteria applying, because this is like an actuarial calculation where you're saying this person is such good prognosis, they'll pay a certain amount of money. If they fail to have a child, because it is live birth as the outcome, if they fail to have a child, we'll refund 20%, 50%, or even in some cases, the entire amount of money that they've spent. So when I speak to patients about this, I say to them, maybe this is an indication of you being good prognosis. You can take it as a sort of proxy for being good prognosis, because these medical criteria apply. So I'm sure it'll be things like AMH, previous cycles, whether you've had any surgery, and so on. And then we have IVF multi-cycle packages. The way you should think of these is they're essentially discounted cycles, because there's no medical criteria. I see it as a patient retention tool. I'm sure you're aware that in a private market, if somebody fails at one clinic, they probably say they didn't do anything, they didn't do everything that was needed, or they didn't do the right things. I'll go next door to a different clinic. So by having a multi-cycle package, it's a way of maybe retaining the patient. And so essentially you get 3 cycles, let's say, for the price of 2. That's my proxy for discounting. And in some cases, additional tests and treatments, the sort of add-ons, may be part of the package as evidence increases. And this leads to my sort of whole, what's the methodology for deciding whether an add-on is now advanced medical care or is just a gimmick? It seems to me that if insurance companies who care a lot about making sure they make money because they're a business, maybe this is a soft evidence of efficacy. So then we've got private insurance and employee benefits. I can't say too much about this because it's private health insurance is not mandatory in the UK. So it's not the majority of people who've got this. Coverage varies according to premium level. And, a lot of these companies now have custom packages. So I think it's a bit meaningless to say, if I have, for example, I have AXA health insurance. I pay for it myself. It's not part of a company scheme. I don't need fertility treatment, so I'm not sure what the coverage is, but I know that you would get more depending on how much you spent. But I know that with some of our patients who come through direct patients, some of their diagnostic tests, which actually includes endometrial testing in some cases, have been covered. But I think that's the coverage for screening and testing is probably a lot more than IVF cycles. And with IVF cycles, I think it's most likely to be a contribution from the insurer or some sort of co-pay system. With employee benefits, so not healthcare insurance, obviously employee benefits can include healthcare insurance, but they're generally very company specific. The growing trend is to have some benefit because of the voice of the patient growing stronger. There's been some controversy in worldwide actually, but including UK, where some of the trendy companies, the forward-thinking companies, have provided egg freezing for their young female workers, and it's been seen as a kind of cynical way of keeping them in the workforce and sort of promoting them, but not really promoting them going off on maternity leave. So there's been some controversy around that. But there's a bigger move towards fertility support, which I'll talk about in a second. So not so much paying for the IVF, but being more caring about the whole infertility issue. And this is an example. I've just put a few. This one's based in the US, this one's based globally, but I've been working with them in the UK, and another group that's popped up called Fertility Matters at Work. So a growing trend to support people in the workplace, to consider that fertility is a clinical problem and a mainstream thing, and not something that should be taboo and shameful. This is great for supporting patients, but this is what I'm saying, not necessarily paying for their treatment, just helping them to navigate the system. So as you can see from the little boxes, they do consultations, you can do one-to-one chats, there's lots of resources, it's confidential, it's a safe space, but it isn't paying for your treatment. It's perhaps just helping you get to what you need quicker, which I think is excellent, but it's not the same as paying for treatment. Very briefly, I'm not going to sort of advertise for Igenomix here. I just want to say, when we consider all the different tests that could be associated with IVF, obviously you're very familiar with the embryo testing. We've talked a little bit from the previous talk as well on endometrial testing, and then we've got carrier screening and a few other things. And I consider these all part of sort of either intrinsic to IVF or sort of adjacent to IVF, these two on the outside. But if a test or treatment isn't approved by NICE, then it can't have NHS funding. And this is what I said about this, what's the methodology for doing that? So NICE requires a lot of evidence, and it doesn't meet very often to kind of review guidelines. So I'm not sure that's a dynamic way of providing, a funding mechanism. And then we've also got the fertility regulator, the Human Fertilization and Embryology Authority, and this is specifically looking at IVF. So they've got a method where they meet, have a scientific advisory, clinical advisory committee, and they've been reviewing the treatment add-ons, and they have this traffic light system. And so if there's limited evidence, well, it's a traffic light with only two colors. It's red and amber. And red means no evidence from RCTs, and then this very small print, which is no evidence to show that it's effective at improving chances for, and this is the key word here, most fertility patients. So there's almost an implicit acceptance that it might work for some people. But I don't know about you, and I'm pretty sure you have traffic lights that I've never been to Japan, but I'm pretty sure you have traffic lights that are red, green, and amber. Most people see a red and it means don't do it. But so it's sort of a marketing tool from the regulator to say, you probably don't want to do this, but actually it's not against the law to do it. It's just they're giving a very strong signal to patients that maybe you don't want to do it. So I think that's potentially a problem, potentially a mixed message for patients, because trust me, since the traffic light system came in, more people are doing PGTA than before the traffic light. So it doesn't seem to have worked. And I've got, this isn't a full list, I just taken a list from the centre, so you can see different things according to the evidence that they've looked at are rated differently. And for example, acupuncture, and I'm not judging whether acupuncture works or not for IVF, but it's done in a lot of cycles as an adjuvant sort of therapy. That's not included on the list. So it's a little bit of an inconsistent system, and I don't think that necessarily helps patients. So let's quickly just talk about some genetic tests. Well, this is my area of expertise. I've been doing embryo testing for a long time. So PGTM, which is for looking at single gene disorders, I'm very proud to say that in the UK, this is fully funded if some eligibility criteria are met, and they're not dissimilar from the IVF eligibility criteria that we discussed earlier. PGT-SR for chromosome rearrangements, pretty much the same, falls into that. PGT-A, as you would expect, is we actually include it when we do PGTM and SR, and that's okay. But as a standalone test, doing PGT-A alone, that's not funded. And so that's a very similar story that we heard from previous speaker. But even things like products of conception testing after a miscarriage, it's free on the NHS, but only after 3 miscarriages. So you can imagine there's quite a lot of patients that would like access to this free at the point of care who can't, and they have to go private. And then carrier screening, and carrier screening is very linked to PGTM in my view. That's not funded unless it's part of a genetic family history assessment, so there's a problem in a family. But the reality is, for example, with cystic fibrosis, 75% of cases where we find a mutation in couples, they don't have a family history. So there's a health economic argument for considering carrier screening prior to any pregnancy, but particularly if you're medicalizing it in IVF. And then endometrial testing, at the moment, it's only funded privately. So what do I think the way forward is for the UK? Well, we need more equitable provision. I mean, I showed you lots of slides saying that it depends where you live, and that's not a good thing for a united nation. We need to, and this is a global thing, I think, we need to understand the declining replacement rate. More people are dying than are being born, especially post-Brexit, when we don't have migration of people into the country. It's much more hard to come and work in the UK now. So, we need to find a way to have more people to pay tax in the future. That's the bottom line. And it's a long-term plan. We need to better recognize infertility as a disease, so it can actually compete with other diseases for tax funding. And we need a better ethnically sensitive and ethical approach to IVF, because, most medicine is being created, by white people for white people. We need IVF to be as efficient and effective as possible. If we're going to spend money on treatment, it needs to be the best care available. It can't be just good enough. And that requires innovation to flourish. Now, we've got a great history of innovation, particularly in this area, particularly IVF. There's a good research framework, but the funding is quite poor for studies in these areas. I've mentioned Roe versus Wade here because you probably all followed the story in the US where abortion laws being overturned, which has an impact on IVF, whether that's stored embryos or doing IVF itself. It's certainly wobbling the IVF industry in the US. But fortunately, we're not getting any ripples here in the UK. So that's good news. And some good news that something great the HVA has done recently is amending the IVF laws to allow a better storage period for eggs. So it used to be 10 years only. And it was actually unfair. Sperm could be stored for 55 years and eggs could be stored for 10 years. It just didn't make sense. So, I'm calling that part of innovation, understanding that the world is changing, that what we understand about reproduction and fertility is changing, and we need to amend the laws accordingly. But I do think we need, if we want to have efficient and effective IVF care, we need to consider these other tests, this advanced medical care, and that requires a nice recommendation. We need better health economic arguments and data to support that, including carrier screening. And we've got this we've got the great advances in genomics, and they're not really being applied to fertility in a consistent way at the moment. They shouldn't just be applied to cancer, they should be applied throughout medicine. And I think we need to relax the thresholds for evidence to fund tests. So for example, the HVA saying it's a randomized control trial only. Well, we all know how difficult that is to provide that kind of evidence within an IVF setting. And that's not just, denying that it's possible, it's just saying it's extremely difficult. So we need to consider other levels of evidence as well. And then finally, if I was giving a report card to the UK for IVF, I'd say it's good. You should be very privileged and happy to live in the UK because IVF is funded and some genetic tests, but we could do better. We have a mature market. IVF funding is funded and recommended by NICE, but it's not consistent, and waiting lists are a problem. So even if you get funding, because the NHS has been under such strain from Brexit, the pandemic, and so on, you might wait for 6 months, 9 months, a year. I know that immediately after the pandemic, one big NHS centre that provides PGTM for monogenic disorders had a waiting list of something like 18 months. Well, patients can't afford to wait for 18 months, so then they go private. Long-term view of IVF as an investment in the country, not just as a short-term fixing of people's problems. It's a way of having a generation of people who can pay tax ultimately. We have a very liberal country, but it is strongly regulated, and I think that's good. But I'll show you some examples from other countries in Northern Europe to show you how different it is just in a next door country. I think it's good that we have regulation, but I think it could be a little more balanced to support private care provision, given that private care is becoming the majority player in this region. And regulation should be aimed not at the infrequent, it should be aimed more at the frequent, in my view. And I've worked for the regulator, and so I've looked at it from the inside. I think we need an evidence-based approach, of course, in medicine, but outcomes can't simply be live birth rate, and they can't simply be based on RCTs. So we might start thinking about miscarriage as an outcome as well. And this balance ultimately between basic routine IVF care, which is non-controversial, but isn't that effective, should be balanced against what we call the kitchen sink in the UK. So when you say you throw everything at something, it's called throwing the kitchen sink at it. And I don't believe that every patient needs everything added to their cycle, but there must be some balance in between, and I don't think we've got that balance right. So just finally, just a few examples of differences in Northern Europe, and honestly, this list could be massive. In Germany, very advanced country, no PGTA allowed, and PGTM, which is pretty routine in many countries now, it's only done on a case-by-case basis. So what happens in these situations is people go overseas. So you don't really fix the problem, you just send it overseas. Similar in Norway, I'm very proud to say that we've done the first PGTM case with a Norwegian public hospital in 2022, but until 2021, it wasn't even allowed. So it was sent overseas. So patients have to travel to another country to get the treatment that they deserve in their own country. In Czech Republic, I think this is kind of a success story. IVF has been state funded for a long time, and so's PGTA. Now, I'm not promoting PGTA, I'm just trying to say that they've recognized that people want it. And as long as it's done in the country, it can be funded. And it's funded from a different pot of money, from a genetics pot of money, which is interesting. And then Netherlands, which has a very good track record of IVF, but no IVF extras, those advanced medical care, unless it's been government approved. So a very fragmented picture across Northern Europe. But even within the UK, I think we could have a better unified approach to IVF. And I think that's it. Thanks very much for your attention.
Thanks, Alan. Well, very interesting presentation where we could navigate a little of this patchwork that is the British system.